Hi, everyone, and welcome back to Poem Peeps. We're so exciting to see you as always. I feel like it's been a while since I've seen you on Zoom, but I guess that's great because the last time I saw you was in person at the annual chess meeting, which was such a highlight to see you, but really excited for us to be back and recording. We've had some great things come out regarding chest and our live podcast there. We've had some great, fantastic fellows case files, but I'm really excited to get back into kind of a core top consult in a way or core content production. How are you doing?
Yeah, I'm excited too. Always a pleasure to see you. I will say being in person for chess kind of spoiled me because we got to hang out and it was your birthday, which was like an added bonus to get to celebrate with you, which was great. But yeah, I'm excited as always to be back recording and talking about in case and then an interesting topic that'll come up in critical care medicine for anyone who spends time in the ICU. A word to our listeners. I apologize. I have a bit of a laryngitis, so you'll bear with my scratchy voice, and that's not your audio quality. That's actually what I sound like.
Good disclaimer, Firth. I love that. But sorry you're feeling under the weather, but glad for all of us to be together. So go ahead and get started with our great introductions. I'm super excited to welcome Hima Veeramachaneni. Hima received her medical degree from the University of Missouri Kansas City School of Medicine, and she completed her residency at Emory, where she was also chief resident at Grady Memorial Hospital. Hima's completed gastroenterology training as well as GI and transplant hepatology training at Emory. Him is also now doing a critical care medicine fellowship, which is a really cool combination of training. I haven't seen that before, Emma. And I will say we have had a prior hepatologist on the show, but you are our first GI hepatology critical care trained guest. So super cool and excited to welcome you to the show today.
Thank you. Being a PGY8 has a few perks to be in this cool subspecialty field, but I'm so glad I'm here and excited to talk about this case with you guys.
Yeah, thanks so much for coming on. We really appreciate it. And next, I want to introduce Kalaila Pais. She is the mastermind behind this episode. She received her MD from Howard University College of Medicine, and she's currently a second-year internal medicine resident at Beth Israel. She's interested in pulmonary critical care and medical education, and she encountered this very cool case and really wanted to share the knowledge that she learned on this podcast. And so we're excited to have you. Thanks for coming on, Kalaila.
Thank you so much for having me. I'm really excited to get into this case.
Yeah, absolutely. And before we dive into the details, just our standard disclaimer. As a reminder, this podcast is not meant to be used for specific medical advice. The views we express today do not necessarily reflect the opinions or policies of our respective employers. The case we present today will be HIPAA compliant, and we may have changed some details to protect the privacy of our patient. And with that, I think we can start diving in. Kalila, why don't you just start by telling us about this case and a little bit of basic information about the patient?
Sure. So we have a 70-year-old female with a history of hypertension, AFib on apixaban, alcohol use disorder, who presented after being found down surrounded by bottles of liquor and maybe food or fluid and coffee ground emesis on her shirt. She was placed on Section 12 for concerns for self-induced harm and initially taken to an outside hospital before being transferred to our hospital for further care. Here, she was found to be hypotensive, requiring vasopressor support, tachycardic, and tachypnic. Physical exam was most notable for scleral icterus and an irregular heart rate, but clear lungs and no evidence of asterixis. She was oriented to person, but not to place and time. Her home meds included apixaban, metoprolol, bupropion, magnesium oxide, and over-the-counter Tylenol, which the patient endorsed taking 10 pills per day. I know this is a brief history so far, but Christina, what is your problem representation and what are your initial thoughts about her presentation?
Sure, not a problem at all, Kalila. Thank you for presenting this case and coming up with this idea. And even though this is short, I feel like this is an initial first encounter for a lot of our first responders and EM colleagues that are getting this information. But what I would put together for a very brief problem representation right now, based on what you said, is that we have a 70-year-old presumed immunocompetent woman with a history of hypertension and AFib on oral anticoagulation, with a history of alcohol use disorder, found to be unresponsive with concern for recent acute emesis, as well as potential alcohol consumption, presenting with hemodynamic instability and physical stigmata of scleral icterus. And I think this brings up a great time for us just to think about what our initial differential diagnosis and thoughts are. And we've had a couple of other cases that have gone through toxic ingestions and consumptions, and wanted to highlight a couple of those things. Obviously, I know as you're caring for this patient, and we all are going to say obtaining collateral information is going to be very important if we can. that can be time sensitive, but not always able to get in a timely manner. So other things, though, that I'm going to be thinking about at this time is you mentioned the concern for potential alcohol consumption by the responders that found her. We have medication list as well. So was there an intentional versus unintentional ingestion as well as possible co-ingestion of medications or substances? Still going on with history, I think it's important. I know Furf and I have talked in a prior episode too, when we're thinking about home medications, understanding if they're immediate or sustained release formulations, given the possibility of seeing delay in clinical findings. And as far as another history, I was actually asking this to a patient recently who had some lab abnormalities as well. It's just really asking about any other over the counter medication, specifically any herbs or supplements that may not be on the current EMR or whatever data that you're using for that. So I think those are really all important things to think about regarding the history. With some of these medications, always important to think about over ingestion, but also about what about withdrawal. I think other things that you mentioned, one thing that struck out to me here is, in this case, scleroicterus. So, really worried about liver dysfunction, whether that's acute, subacute, or more chronic. Things that you also mentioned, she's on oral anticoagulation. So, she's having some acute liver process going on with potentially impairment of liver synthetic function as well. As that predispose her more to a coagulopathy? So, that would be something that I am worried about, but always just to be thorough in the process, want to include, is there anything acute, like a cardiac manifestation, whether she's had a MI or recent arrhythmia, any type of neurological differential, including seizures? We always want to bring up endocrinopathies for our endocrine-liked folks, so either hyper or hypoglycemia, or potentially any recent trauma that we're not aware of. So I feel like I talked a lot right now, but acute problem representation, certain things to think about. But I know you'll be going over some additional information, so I know that we'd love to hear that.
Yeah, Christina, I love the saying broad on the problem representation like that because I feel like the thing that people do is narrow down so much. I was just going to comment with one thing about the scleroicterus. I feel like scleroicterus is actually one of those really helpful findings because it's very specific. Like, you know that the patient has a bilirubin level above 2 or 2.4, whatever you had read the cutoff is. And the list of differential becomes shorter. Now, that doesn't mean people can't have multiple things going on. So I've certainly seen people with scleroicterus, and it turns out their main problem is something unrelated. But for the scleroicterus itself, I had always learned the buckets of hepatocellular. You have your liver that's really just not working and processing. Extrahepatic, which is a little bit of a misnomer, but basically obstruction of the bile ducts. Like, you have a pancreatic mass, or you have something that's going on with the bile ducts themselves that's leading to cholestasis or stasis in the biliary tree. And then always hemolytic anemia. You're just splicing through red cells for some problem. And so it's nice because we get to keep our broad differential, but we also can focus in on, we have to find a reason that this is happening. But with that, I am similarly curious for more collateral labs and any other data that you have for us, Collab.
Yeah, so we were able to get some collateral. The patient lived alone at home, but she did have family members who would come occasionally to visit. During this presentation, her family had actually been on vacation, and when they came back, that's when they found her down. She had a history of alcohol use disorder and major depressive disorder, but no known history of suicide attempts in the past. In terms of our objective workup, although the patient didn't have many major imaging findings except for a few rib fractures, she did unfortunately have quite a few laboratory derangements. So I'll go through the long list of them. She had a mild leukocytosis to 11.4, a macrocytic anemia with a hemoglobin of 9.5, a slight hyponatremia, a hyperkalemia to 5.8, hypocalcemia, hypomagnesemia, and hypophosphatemia, as well as a significant hypoglycemia to a glucose of 20. She had an AKI with a creatinine of 2.8, and her baseline was 0.5. And then she had pretty significant metabolic acidosis as well. So her pH was 7.04, bicarb was 8, PCO2 was 54, and her lactate was 16. And her LFTs showed an AST that was greater than assay, which is greater than 10,000, an ALT of almost 3,000, a T-Billy of 5.8, and an ALK Phos of almost 200. So that was also a lot of information, and there's a lot going on with this patient. Dave, now that you've heard some of her lab findings, what is something else you're thinking about, or what are you most concerned about?
I'm mostly thinking, yikes, that's certainly a lot going on for a patient. So to try to summarize it, we have a patient who has significant kidney injury with a metabolic acidosis and essentially metabolic disarray is like how I would describe her electrolyte derangements with a severe transaminitis, but also an elevated bilirubin. And then interestingly, no anemia, only mild leukocytosis, maybe a little bit more of a normal CBC than we might expect. So when a patient comes in like this with a significant derangement, my first thought is stabilization, right? Like lactate is 16, pH is 7.04. They're starting to retain PCO2. I just need to make sure this patient is perfusing and ventilating appropriately, like basic tenets of critical care. And then I can start trying to piece together put it all together. One thing that I am drawn to with this is certainly with a lactate of 16, I'm worried about hypoperfusion. Obviously, we can talk about other causes of lactate and with liver dysfunction, which we'll get into, not clearing, but this is a very high lactate. So this patient was hypoperfusing at some point. And then right after that, I'm drawn to the significantly elevated transaminitis. So we have an AST of 10,000, ALT of 2,900. These are really high LFTs. So there's only a few things that really do that. And shock liver is definitely one of them. So it could all just be explained by hypoperfusion. We often read about this AST, ALT, alcoholic hepatitis, like more than 2 to 1. And so this fits that. I will say one thing that I encourage people to always check is a CK in these cases, because if you have a CK that's up, it can throw up that ratio and the patient may just have rhabdomyolysis from being down. And it's not hepatocellular injury directly. It's more from the hypoperfusion. If it is a primarily liver thing that is causing this, then I'm really thinking about toxicities, right? So Tylenol toxicity certainly comes up, acute alcoholic hepatitis, maybe this would still be really high, and then other drug-induced liver injuries. But rip-roaring infectious hepatitis sometimes could do this, but this would still be extremely impressive. So those are the main things I'm thinking about for this. And so I'm really going to be supporting this patient, trying to get them perfusing better, getting more history to try to tie this all together. I will say that with this collection of labs, often you just end up seeing infection. You often just end up seeing sepsis and shock, and it can present like this with an acute kidney injury and an acute liver injury, and then you're just left picking up the pieces. But as Christina was pointing out, you have to be really broad because it could not be that. It could be that they had a toxic ingestion that started either the kidney or liver injury, and then everything went from there. They just weren't eating, drinking, eventually went down. Could be that they have a severe endocrinopathy that sort of led them into a complete metabolic disarray. People will come in severe thyrotoxic or severe hypothyroidism can come in with labs that look like this, hypoglycemia, really hypovolemic, and then they get into a bad situation at home. And so I think about all these. I will say one thing that catches my eye here is the bilirubin in the acute setting. So like when we see shock liver in the ICU, we often see this pattern of a massive transaminitis and then a delayed bilirubin elevation. So the fact that this patient already has a bilirubin elevation, she has history of alcohol, she takes a lot of Tylenol at home at baseline. So it does make me wonder about a primary sort of liver toxicity that's causing this, given that she already has this lab presentation. And then other things that I could ask about or look for that would make me think about the liver driving all of this. The symptoms of liver failure can be very nonspecific: fatigue, lethargy, nausea, vomiting, anorexia. Other things are more specific. Rip-roaring hepatitis hurts in the right upper quadrant, and you shouldn't see another cause for it. Jaundice or itching, certainly we think of obstructive jaundice as doing that. You mentioned she did not have asterixis on presentation, but I would always look for that in any patient who has jaundice, because that would be a signal to me that they might have accumulation of ammonia. And again, I'm worried more about their liver. And then even beyond these labs that we have, I would like really be looking for a full panel, mostly for underlying causes, but then to see the level of dysfunction that's happened. I end up trending the creatinine, looking at LDH, trending the acidosis. And then finally, to get a better sense of how her organs are working. For example, with liver disease, I would start looking at the albumin, I would start looking at the ammonia, start looking at the INR, thinking about synthetic function. I might also try to get some sense of chronicity. So somebody who has like cirrhosis usually can have some degree of thrombocytopenia along with it. Someone who has like normal platelets, again, you can be tricked and it could be acute, but I would look for signs like that. So I still have a lot more questions. I will be honest, my first differential would be like, what caused this person to go into severe shock? But then with the history we know, I would start really thinking about, can we get our kidneys to recover quickly? Can we correct this acidosis? And then is her liver going to be working? And was her liver a victim of this disease or the cause of this disease?
Yeah, I think if I could chime in for just a second here, I think the thing that I always worry about when I look at this is what Perf said, which the symptom or is it the problem? And I think a lot of times in liver, it's the symptom and not really the problem. But in this situation where we're worried about the alcohol use potentially being a chronic underlying factor, and then conjugating factor now being the Tylenol use and maybe overuse over a long period of time. Certainly, I think shock liver should definitely be on your differential in this. And as Verf said, the bilirubin always lags behind. So it's interesting that her bilirubin's already high, which makes me think there's more than one process and not just shock liver, or it's been happening long enough that the bilirubin got high enough to be a problem. Viral, I really think about immunocompromised patients. And at this moment, other than a pregnant lady that can have like a HSV hepatitis that can get pretty severe, in immunocompetent patients, it's unlikely to have such severe of a presentation of like CMV, EBV hepatitis, but certainly is on the differential when you have enzyme elevation. And I think in somebody like this, that the family wasn't sure what she was taking or how much she was taking. And I often see that people underestimate the amount of Tylenol that they're taking at home, or forget that supplement that they saw on Amazon, or in the weight loss trends that we have these days. There's a lot of different supplements that are being used in the weight loss trends. And so I think certainly medications have to be very high on your differential. And it's not clear how long she was down, which could mean that this ingestion happened a few hours ago. But given the degree of elevation, I would say it's probably been either like a chronic injury or having been happened over the preceding days.
Yeah, such great important points to add, Hema. So thank you for that. And for yeah, I love the fact that you brought up just checking CK in this. I do that too. So I'm like, who did we learn that from when we were
Yes, I
residents,
agree.
right? So but definitely agree with that. And I think we're an interesting point in this case too, right? But this patient, we know she came in with hemodynamic instability requiring vasopressor. So the ICU is the best place for her. But Kalila, I'm wondering if you could tell us a little bit more, right? Because I think at this point, understanding, is this acute liver injury? Is this acute liver failure? And just helping listeners understand the difference between the two, because I think that's really important also when you're thinking about triaging a patient to make sure that they're at the appropriate unit. So love to hear if you want to share a little bit more about that.
Yeah, and this was a big learning point for me because I knew that acute liver failure and acute liver injury were different, but I didn't really know exactly how. And so I learned that they're actually on the spectrum of liver injury, and they both have coagulopathy and they both have jaundice. But acute liver failure is different because of the speed of onset and the presence of encephalopathy. And the encephalopathy that we see in acute liver failure is different from what we see in chronic liver failure or cirrhosis. So, the encephalopathy in acute liver failure is because of widespread hepatocyte necrosis. And that's causing ammonia to be released from the cells, and that's able to travel around the blood and can even pass through the blood brain barrier. And it can cause astrocyte swelling and can result in cerebral edema, which is like the big complication of acute liver failure. And this is different from the chronic liver failure and the encephalopathy that we see in that, which is due to portosystemic shunting. And I think another big thing to think about is that the strict definition of acute liver failure is all of these things in a patient without pre-existing liver disease. And so if we see somebody coming in with all of these things, with a history of liver disease, we call it acute on chronic liver failure. But the one question I had for Hema was I had looked into how we can subclassify acute liver failure based off of its chronicity. So there's this fulminant or hyperacute, acute, and subacute, but there's maybe some variation on really the timeline for all of that. So I was wondering if you could help me out a little bit on that.
I wish I had a straightforward answer from you, but from a clinical perspective, I think the idea is the amount of necrosis in a short period of time is ultimately what leads to the acute liver failure. And so the short answer is it probably doesn't matter as long as it's less than 26 weeks of whatever insult it may be. But of course, fulminant liver failure or like something that acutely happened that led to very significant hepatic necrosis is a lot. People get a lot sicker quicker. So certainly somebody that you know that had an ingestion or somebody that had a specific insult that led to their hospitalization, you would just worry that they're going to turn the corner and get much sicker before they get better. I would say from a clinical perspective also, I have seen where people have had cirrhosis or have had autoimmune hepatitis long term and then get a severe flare. I know that the definitions don't really account for that patient population, and that ALF subcohort in somebody with chronic liver disease can also be pretty deadly and cause significant problems. I will also say that there's like this multi-system organ dysfunction, the cytokine storm that leads to this severe vasoplegia that leads to the significant shock is one of the biggest things that's concerning. And that is definitely seen more in like the fulminant rapid liver failure than more of the subacute process that you might.
So, Dave, I was wondering if you could tell us a little bit more about how you think about admitting somebody with acute liver failure.
Yeah, absolutely. These are scary, right? These are scary admissions when someone comes in rip roaring acute liver failure. I really like that you pointed out that our hinge point here is really about their mental status, right? Because that is what's making us one concerned about their mortality, but two, like how quickly their liver is functioning and progressing. And for some places, I won't speak for all of them, like that's the difference between getting listed for a rapid transplant or not. Like you could have terrible labs, but if you're still with it, they have time and they're going to wait for it better. So that brings me to my first one, just going sort of in systems order. I worry a lot about the CNS. I think we're very used to people coming in with hepatic encephalopathy and even bad encephalopathy, and they need to be intubated for airway protection. And we care about all these things with the acute liver failure. But what we really care about is in the acute failure setting, in a hyperammonemia setting, you can really get cerebral edema, and this can lead. And so you have to monitor for those things. A pearl is you also get that hyperammonia in patients who just came out of a tip sometimes. And so if you have someone who was wide awake and then all of a sudden is not talking to you after tips, you check them when you get a CAT scan to look for cerebral edema because you're going to have to be doing some acute management and maybe some dialysis to help them out. So I really worry about their mental status and whether or not they're protecting their airway, but also what's going on inside their brain. People with acute liver failure are super, super sick. And so they can have complications every organ system. So I won't go into each and every one of them. But one thing that Hima pointed out, I think is a major one, is that these patients really go into a vasoplegic, really severe distributive shock state. And we call it sepsis a lot of times when they come in, but it's really their liver dysfunction, this totally dysregulated splanchnic vasodilation. And these people are on high doses, multiple pressors, and it's just really difficult to maintain their vascular tone. And so I really worry about that. From a cardiac standpoint, they actually often have a high cardiac output state given this severe reduction in their SVR. And in the acute liver failure, I'm worried less about some of the pulmonary cardiac complications we see in chronic cirrhosis. Like I see a ton of portopulmonary hypertension and hepatopulmonary syndrome, but I'm less worried about that in someone coming in like acute liver failure and more in someone who's had development of cirrhosis over time. Just like this patient had, you're going to be very prone to renal failure, mostly because the regulation of vascular tone with the liver and kidney are so closely related, but also this bad vasoplegic state. It's not uncommon at all for that to end up on continuous dialysis. You also often go into metabolic disarray. You have this combination of the shock, liver failure, and renal failure. And then you also have some contributions from the liver itself. So you have hypoglycemia like this patient had because your liver plays a role in glycogen production and gluconeogenesis. And correcting some of these electrolyte abnormalities, low glucose, low phosphate can be really important and make sure that we're keeping up on them. And then all the traditional complications of liver failure that we worry about, coagulopathy, pulmonary portal hypertension, and the complications that come along with those. Bleeding ends up being a major issue for a lot of these patients. So we really have to be monitoring each and every one of the organ systems closely in these patients who are coming in, and they come in often. And then beyond this, beyond doing the stabilization, we're thinking about next steps. And a lot of time, the next steps is just about making sure we know what caused this, or at least have a sense of what caused this. So we already know this patient had some chronic Tylenol use. And then we know that Tylenol is the number one cause of acute toxic ingestion liver failure in the United States. So that's something that we're going to be high on our differential and we're going to check for it. But there's a million other things that cause liver toxicity. Livertox.com. I feel like you can enter in any medication and you'll find somebody who's had liver toxicity from it. But we can look for it if they take in other things. We already talked about the many viral infections in Hima. That's really nice to know that very few of these present in such a rip-roaring state. All the hepatitis is EBV, CM, VZV, HSV. And then we are also already touched on shock liver. Then, just general systemic illnesses can certainly have manifestations with liver injuries. The heat stroke, autoimmune conditions, malignancies, HLH, like these all are less common, but causes of patients who can come in with pretty bad acute liver injury or acute liver failure. And I don't think we'll dive into all the complications that can happen with pregnancy because I don't know that we'll tackle it here. And those are really scary. But so this patient we know is coming in hot too. We already talked about a bunch of the stuff you're going to have to do. Clyde, can you tell us about the workup that was obtained for them and how the next steps?
Yeah, so we did obtain a hepatitis viral panel, and it showed that the patient was Hep B non-immune, but there was no evidence of active Hep B or active Hep A infection. We also did test for CMV and EBV, which the patient was exposed to, but again, no acute infection. And I know everybody's big question was, what is her Tylenol level? And I'll tell you, it was 41. And I think the upper limit of normal is around 30. So for me, it was interesting because yes, it's elevated, but it's really not that high.
Great. Thanks, Kalaila. Yeah, and I think that it's like, what do you actually do with that number and how do you interpret it? How long was she down for? And I'd love, Hima, for you to tell us a little bit more about this. I think you have such your unique perspective with your transplant hepatology and your current critical care training to really shed some insight on Tylenol toxicity. So I'm wondering if you could talk to us a little bit more about it and specifically, how would you interpret this Tylenol level? And for those listening today, what are things that we should become standard of care as far as treatment and management goes if someone's coming into the ICU overnight?
Yeah. So starting off with how do we interpret this Tylenol level? And I think the biggest takeaway that I will say from this moment is that if you don't know when the ingestion was, that Tylenol level can be very concerning or very not concerning. And so it's really hard to interpret that in this current situation, just given that we don't know if this was like a chronic, a repeated super therapeutic ingestion, meaning that she was taking over the recommended amount daily that led to Tylenol buildup and then a hepatic necrosis issue, or if this was like an acute thing where she took more than she normally does and that led to a significant acute problem. I think one thing I will say is if we knew that she ingested it 4 hours before she came in, and that's when she took a bottle of Tylenol, for example, a level of like 100 or 150 would be very concerning. In the setting of this 41, if it was, you know, 5 hours ago, then maybe not that big of a deal to cause a fulminant liver failure, but if it was, like, 24 hours ago, that means that the level was much higher at the time of ingestion. I think that one of the things that can help us is talking about the pathophysiology of how Tylenol does this. So the key factors in this is that Tylenol is absorbed pretty rapidly from the GI tract, and so the therapeutic level usually comes within 30 to 120 minutes of taking the medication. So that's why that Tylenol level at 4 hours can be very impactful of letting us know, was there a significant ingestion or not? The way that Tylenol is metabolized in the liver, it gets broken down into NAPQI, and then ultimately glutathione causes it to turn into non-toxic metabolites that are excreted in the urine. Unfortunately, this pathway gets overwhelmed when you have a significant Tylenol overload, which then leads to binding of this NAPQI to the liver cells and leads to necrosis. And then the amount of necrosis then leads to determine what complications you have. And I will say the pathophysics of the complications, a lot of times you have decreased synthesis of coagulation factors that lead to the coagulopathy that could be refractory to even trying replacement with vitamin K, for example, just because the liver is unable to keep up with the production. You get this massive macrophage induced cytokine storm that leads to the vasopresia and the shock. And then the hyperammonemia is because the liver is no longer able to process ammonia through the urea cycle. And so a lot of it goes to the brain, leading to the brain changing ammonia to glutamine. And then that glutamine leads to astrocyte swelling and cerebral edema. So in that context, you really see nausea, vomiting, lethargy, diaphoresis, all of that kind of stuff in the first 24 hours in a very significant acute ingestion. And then over the following days, you will see the hepatotoxicity, the nephrotoxicity, and the multi-organ failure. And they either go one of two ways. They get better or they don't get better. And one of the kind of tools that has been developed is the Matthew nomogram that in the past has been revised to give us a clinical suspicion of which direction people are going to go. And acetylcysteine therapy is going to be helpful in those patients. The nomogram essentially plots like the level of Tylenol at a certain time point after ingestion. And if it's above the treatment line, then it indicates that there's a pretty high risk of hepatotoxicity, and that could be very helpful. I think the downside of this in a lot of situations, as it is in this situation, is the time of ingestion is often unknown. And if you don't know the time, the level and the nomogram aren't very helpful. So I will tell you that NAC can be helpful to prevent transplant or need for transplant, and it has very low side effects, especially because generally we're using the IV form. So, like the typical like nausea or other things that are associated with the oral form of NAC aren't really applicable. So, I would say starting NAC in the situation where you're not sure about time of ingestion, you are aware of a history of Tylenol use or overuse, and have a positive Tylenol level is a no-brainer. NAC should always be started in those situations. Sometimes if you're lucky enough to catch them early enough, you can use activated charcoal to try to prevent the GI absorption, but generally that's within the first 2-3 hours. And I will tell you that very unlikely for patients to present that quickly. That's the very minority of patients. And so after 3-4 hours, it really doesn't have much benefit because the Tylenol is already getting absorbed. Discussing a little bit more about NAC, since that works on the actual mechanism of how acetaminophen is broken down in the liver, it actually binds that NAPQI, which is why it works. And so I generally would say in most cases, as long as you have a known history of Tylenol use, a known like liver enzyme injury, AST, ALT are elevated, that's a good safe bet if you're concerned about ALF. And then the part that I think uses my expertise the most is the use of CRT and or Plex in these patients. And the mainstay of therapy in patients with ACLF for hepatic encephalopathy is lactulose and rifaximin to try to poop out the ammonia, acidify the colon, all of that. But in patients that are in ALF, they're often in very significant shock, have very significant pressor requirements, where lactulose is really not the therapy that you use for hyperammonemia. You're usually using CRT. And in this patient, she had multiple reasons for CRT, this refractory lactic acidosis, the significant metabolic acidosis, and AKI, but also for hyperammonemia. You generally worry about hyperammonemia causing cerebral edema and or herniation at a level of greater than 150 in acute liver failure patients. That's the level at which point you're concerned that the body can't metabolize things fast enough because their body hasn't been used to that ammonia level to be able to process it. When we talk about CRT, I always like to mention that if you're at a center that doesn't always use CRT for hyperammonemia, really think about how much you're dosing and rating the flow of the CRT. To clear ammonia levels, you really should be using doses of 90 cc's per kg per hour. So that's very high compared to what the typical CRT dosage is, which is like 15 to 20. So this is not your standard CRT just for renal clearance. You're really using it for hyperammonemia clearance and lactate clearance as well to stabilize patients. And then plasma exchange has been the it thing in ALF as of late. There's actually been studies, Larson et al. In 2016 looked at high volume plasma exchange and refractory shock and coagulopathy in these ALF patients to try to reverse that and stabilize them. More recently, in 2022, standard volume Plex has also been shown to be just as effective with decreased complications. So you're not using those high volumes of FFP or blood products that could lead to taco and trolley and make the situation worse. I will say that the timing of Plex and when to use Plex is very tailored and very clinically oriented. A lot of times we use it when CRT is not helping alone in terms of stabilizing a patient or people are continuing to decline despite CRT. But the idea is that the data has shown, RCTs have shown that it actually leads to 21-day transplant-free survival in some of these patients because it targets that cytokine storm and takes out those interleukins and other factors that are leading to that.
Hima, are those trials, are those patients also on CRT and they're doing
Yes.
this? Okay. So it's not just that you're doing clearance of the same factors, it's really the additional clearance that you're getting. Wow.
Yeah.
That's
Yeah.
cool.
Yeah, so it seems to make a difference, especially in patients that may or may not be transplant candidates for various different reasons. This could be like a potential way to bridge them to improvement. Now, I will say that a lot of times it's a bridge them to transplant, which of course is why a lot of these patients are transferred to a liver transplant center so they can be monitored closely, get these advanced liver supports that can be used. The King's College criteria is a set of clinical guidelines that can assess the prognosis of patients with ALF and like really determine if their parameters are indicative of needing a liver transplant or not. And I will say the first 24, 72 hours can determine the trajectory of if somebody is going to get towards transplant or need transplant or not. And in this situation, the MELD score is not really important. It's really determinant of do they meet the diagnosis of acute liver failure that you mentioned, Kalaila? And then are they improving or not improving despite maximal supportive therapy? If they're not improving, they get listed as status 1A for liver transplant, which puts them at the top of the list around the country. And
Mm.
so you get first offer. And the hope is that you're stabilized enough to be able to tolerate a liver transplant at that point. The one point that I will leave you with is that you can herniate on the table when you're getting your liver transplant. So the brain is the most important thing to think about, as Firth said earlier.
Now it sounds like you had a traumatic experience.
Yes.
Unfortunately.
Yes.
That is all super helpful. Yeah, the nomogram with Tylenol toxicity and the NAC is always interesting to me. I feel like it's from a time when we didn't use as much NAC. Now I feel like NAC flows like water when you have
Yeah.
acute liver injury, and we're like less distinguishing. But I have still always pulled up nomogram, maybe just for teaching, personal
Yeah.
curiosity when people come in. So just interesting note. Yeah, Monty, what do you think?
Yeah, Emma, just wanted your recommendations as well, because I know when you're thinking about the concern for cerebral edema, thinking about electrolyte management, what is your recommendations for sodium?
Yeah, so generally 145 to 150 is where we start for sodium goals and the typical like cerebral edema protocol with hypertonic saline boluses and a drip to try to maintain that. Sometimes we go even higher. I will say that I am not ever ashamed or think so much of myself to not get neurocritical care involved in those situations, even at the quaternary center where we have a liver ICU. A lot of times in these complex cases, we will have neurocritical care weigh in to try to help us with the cerebral edema protocol. Continuous EEG is a big component of that to make sure we're not missing seizures. Doing non-invasive pupillometry every hour, every 2 hours is a good way to catch a potential herniation or edema early. And I think that the neurological portion of this is sometimes the thing that's not thought about right away, but it should be the thing that should be in the forefront of our minds peri-transplant as well.
That's great. We should make a video showing pupillometry. Glad you started showing you it in the unit. It's so great. It's the coolest invention. But there's a lot of downside to know how to use it, but it's pretty easy. One more question for you, Emma, before we hear more about the case, because I want to hear, Kalaila, what you guys did. You said they get listed for 1A transplant. So it's always interesting because the patients might be drinkers. They might have just had an intentional Tylenol overdose. Can you just talk about how that weighs in, or if it weighs in these sort of acute Tylenol toxicity liver failure patients?
Yeah, so this is an ethical question that I think all hepatologists and transplant surgeons have. First, I will say that in somebody with known psychiatric history, we often get psych involved to give as a risk assessment. So that's one thing that should be considered in every situation where you're concerned about an overdose. But the second thing is that a lot of times this is like a situational thing that you can't take one moment out of somebody's life to say that they shouldn't be given a chance. And so a lot of times we're thinking about, do they have a support system? Do they have other things in place that will help prevent this from happening again in the future? And a lot of times, even now in the transplant world, we are focusing on alcoholics and getting them transplanted on their first episode of ALK-HEP if they're very severe, and then putting in the things in place post-transplant to prevent recidivism, ensure they have support and psychiatric resources. So I think in these situations, it can be tough. Our psychiatry colleagues can help us a lot in determining if this is a good potential bridge for them to be able to live meaningfully afterwards, or if they think this is going to be a concurrent risk. But social support and kind of that psychiatric evaluation can be big factors in determining if it's okay to list them or if we feel like they won't take their medicines, for example, post-transplant, because this is a big psychiatric.
Yeah, it's great. It's always felt like a very beneficent policy overall. It's like we're trying to help people and they just want ingestion and we should give them a shot, which I love. So Glad, can you tell us which of these managements this patient received?
Yeah. So, like Hima said, we didn't know when she ingested the Tylenol. And so we couldn't use the Romac methanomogram and we weren't able to give her the activated charcoal. But we did start NAC because we were concerned about Tylenol ingestion for her. And she was really sick when she came in. And then over the next few days, her LFTs actually downtrended and her metabolic derangements got better. And then our next big question for hepatology was, when do we stop NAC? And so I was wondering if you could talk to us a little bit about that.
First of all, I'm so shocked that she got better, but I'm glad that she did. I think there's not a uniform, this is the day to stop or a certain amount of time. I would say that AST, ALT coming down isn't always a sign that things are getting better. And that's one caution I will mention. Sometimes the liver is burnt out so much that the AST, ALT are downtrending. So looking at your other parameters like INR and making sure that's also coming down and lactate is coming down, those can be your other indicators that truly the liver is getting better because the AST, ALT are coming down and the INR is coming down. If you look at some of the parameters in the literature, INR less than 2, an AST/ALT that has normalized or decreased about 50% from the peak, low, an undetectable Tylenol level, and then the patient is clinically overall getting better from their shock could be good parameters to also stop the NAC. But just word of caution about improving LFTs alone may not always indicate that things are.
Oh, that's such a fantastic point, Hima, and I think great for listeners to be aware of. So, Kalila, I know we're getting close to our time together today, but would love for you to tell us the rest of the management for this patient and ultimately how she ended up doing.
Yeah, so she had a pretty complicated hospital course. She ended up needing HD because we were worried about ethylene glycol toxicity too, because we saw crystals in her urine. But she did have some slow improvement and she had a lot of family support. And a lot of them were actually hoping that she would be able to get better, leave the hospital, remain sober, and then hopefully get a liver transplant. But unfortunately, her mental status did get worse and she needed to be intubated for airway protection. And then she started having a worsening or an increased pressure requirement. And we found out that she had a GI bleed and that needed to be embolized with IR. And so after talking with her family, it was ultimately decided that she would be transitioned to comfort focused care. And she was compassionately extubated shortly after which she passed away.
That's really tough. It's always hard when a patient comes really sick and then actually gets better too, and then has the hospital complications that we know are so common with significant underlying disease. So I hope that you guys were able to take some time and talk together as a team and debrief. It's really important that we acknowledge how much of a toll this can take on us. And there's only one way to do it, which is talk about everything as it happened.
Yeah, thanks so much, Kyla, for bringing this case to us today. And really, as Furf said earlier, being the mastermind of this episode. A lot of great things to talk with, and him as our first transplant GI critical care expert. Definitely appreciate your time and expertise that you provided today. I know that we're at the end of our time together today, and Furf and I always like to end each case with a great takeaway point. I will say mine. I feel like I'm not trending because I was not aware of the CRT plus Plex possibilities. I love these episodes because I always learn something from them as well. So something that I'm going to look up as just a teaching point for today, consideration of CRT plus Plex in certain populations if they're not improving on CRT alone for hyperammonia. Or what about you?
Yeah, I'm going to take mine from what Kalaila taught us about thinking about acute liver injury versus acute liver failure. I think the big distinction is having evidence of encephalopathy. And then it's really helpful understanding the pathophysiology behind that. We're thinking about cerebral edema. We're thinking about hepatocyte necrosis and the secondary effects of that. It's a really important thing for everyone to remember. Hima, did you have any big takeaway you want people to keep in mind?
The brain. That's all I will say. It is the thing that scares us the most, the thing we should look out for, all the non-invasive things, and trend those ammonia so you can be acutely aware if there's a change in your neurological exam.
Ooh, I love that because I feel like everyone learns not to trend ammonias in chronic
In
about
ALF,
yeah,
yes,
that's not this. Right. So that's good.
yes.
Kalila, what about you?
I learned that it's not very easy to follow the Tylenol levels or the rheumatic-nomogram because it's really just about the time of ingestion. And so if we're concerned at all about ingestion and acute liver failure, we should just let the NAC flow.
Like it. Awesome. Thanks so much for coming on the show. This is a great episode. Thank you all for listening. Make sure you like and subscribe wherever you're listening here. And this episode was written, produced, and edited by myself, Christina Montemayor. Original music by Eric Rogers. And we will see you next time.